Welcome, everyone. We may as well get going now in the interest of time. So we have some people in person, welcome, and then some online. For those that are online, if you want to ask questions of Dr. Qaddori throughout the chat, just type into the chat, and I can ask you questions on your behalf. Yeah, you're okay with questions kind of?
Yeah, I think it's better because it's quite long. So we basically have to skip through some slides. So see what's interesting, what's not.
Okay, so there might be some votes onto what people love, some voting onto what people want to, I'm more interested in.
I don't have anything else to do.
Okay. But they want, he did say he could talk till midnight. Yeah. No, we have to be selective. I got stuff to do too. Yeah, well, I'll hand it over you to Dr. Qaddori. Welcome, actually. It's kind of a bit of a milestone. Dr. Qaddori is our first sport medicine fellow for us to host here at Banff Sport Medicine. So it's actually really exciting to have you here for the last few months. It's been fantastic.
We're going to get a flag, for example.
Maybe, yeah. Maybe we'll get you a plaque. Yeah. Or a jersey, some flag. I'll hand it over to you. Yeah.
Is the voice clear or?
Yeah, if you're able to understand, I'll be for the 7.
Okay, yeah. So I'm just going to talk about stress fractures in general. I'm happy to take a question, as I mentioned, in between. I structured this as a general revision about just how the bone structure initially, so just a slight introduction, then risk factors, whether it's biologic, sports-related, mechanical, and the biomechanics. And then we're going to dive into clinical features. And then there was a discussion of the high-risk stress fractures. So there was about 7 or 8 of them. And we probably, for the sake of time, we might pick 1 or 2. And then we're going to go to prevention and basically treatment of those. Sound good? Okay. So just a visual context. So this is our trabecular bone. That's basically calcaneum. For example, if we think of it, pelvis, this is our cortical bone. And these are the osteocytes we always talk about, and these are the canaliculi connecting the osteocyte together. Osteoblast here. So these are basically the cells in general. We talk about the bone. That's the bone marrow, and that's basically the cortex. And this is how the cortical bone looks like. That's another scanning electron microscope. This is the Haversian system we always talk about, which is how the bone canaliculi are formed, and then how the blood vessels and how the osteocytes are lining inside the bone. Third revision, which is how the bone gets more built and resorbed. So this is basically an example of what we call the cutting cones. And these sometimes it's what the bone healing, which is by primary mutation, they call it even sometimes with fractures. If the bone ends are too close together, there won't be any callus. So just the osteoclasts can advance, and then subsequently the osteoblast, and then the osteocytes, and they will lay down the bone. And this is a little bit more magnification of what usually happens. So osteoblast, and then the rest of the cell follow up. So there will be bone resorption, bone formation, and that's how the bone corrects itself or heal itself from injury. A little bit revision about how the bone usually formed. These are the theories about how the osteocytes basically lay down bone. There are 2 theories. One of them is the fluid through the canaliculi, which we showed up earlier, and these are basically the osteocytes, and there is fluid pass through these areas. Some say this will create some electrical charge, and this is how the cells start laying down bone. Some will say it's the movement of the fluid, which is the shear stress that act on these cells, that will stimulate the osteocyte to lay down bone on one side and resorb, and then the osteoblast come and take out the bone from the other side. Here is some what we call the minimum effective strain, which is a measure of the force that's need to be applied to the bone and how this affects the bone structure. So there is 2 sides of the spectrum where the bone can be resorbed, which is if we leave it and then there isn't enough stress on the bone itself, the bone starts getting resorbed. And sometimes if the bone is not having enough time to heal, then they end up having just a wooden bone when the stress is higher as period. I'm happy to take questions. So that's where we're going to enter to the stress fractures. So the bone is dynamic tissue. It has a lot of different type of proteins. So starting from collagen 1, osteonictin, there are other type of proteins that constitute the matrix, and then you have the cells, and then you have the calcified matrix in it. So it's a dynamic tissue that undergo a lot of change. And then the mechanotransduction is how the osteocyte basically sense the stress, and this will help the bone grow in one side or getting resolved on the other. For the bone to be formed, it's considered that you need like a force higher than the body weight in general, and this is more of an explanation bare activity, how much the force that goes through the bones in general. So swimming basically zero. Sometimes it's actually negative in terms of how much stress or strain going through the bone. And if we want to build bone, it need to be 4+. So things like from power jumping and then resistance and strength training. So running by itself or walking, it's good for cardio. It's not really good for building bones. Then comes the concept of stress, strain, and how the bone heals itself. So stress, by definition, is the force that's being applied to the bone. So anything external, jump, resistance training, these are external forces. Strain, by term, it's what the bone senses. So that's how the force gets transmitted through the bone. So stress is external, strain is an internal characteristic of the bone tissue itself, and that's the natural cycle of how the bone kind of deals with stress. So there will be always some micro damage. This will sometimes it creates stress reaction. If it didn't heal or the bone didn't make it in time to repair it, that will progress subsequently to a stress fracture and then a complete fracture. Questions? No. So if we go by sport-specific risk factors, so I divided these into a sport-specific, anatomic, and it's also biologic. So all of these risk factors that will predispose people to having stress fractures. So every part of the body by sport is susceptible to a stress fracture. The interesting part here, it's only the skull actually not having stress fracture. And there's something about interesting about how, in terms of evolution, it says it's actually the tougher bone in the body is actually the skull, although we don't use it for locomotion. It's not really needed for strength. We're not really butting heads all the time. But the lower limb is the most susceptible to stress fractures. And by evolution, the lower limbs have been adapted actually to locomotion. So they are actually lighter, less tough, because the idea of it to make people move. It's not meant to withhold stress too much. So that's also part of the predisposition. Most of the stress fractures usually happen in the lower limb. In addition, any questions about this gentleman? Okay. In terms of sports, the predisposing factor to stress fracture related to training is this is the cycle, which is the first 2 to 6 weeks of introducing a new program in general. And the risk usually gets less after the first 40 days. The suggestion here is how you wanna structure the training program, and in general they will say, yeah, every 3 weeks you have to get every 2, the third week need to have a less basically training to let enough time to heal, and then you cycle the training cycle if you want to introduce a new training program to the athletes. That's the general basically advice. And then in terms of other sports, this is how, as a sport-specific risk factors, this is pair sport and how this basically pair body parts in which sport kind of predisposed to a specific stress fracture in certain region. Yeah, I mean, it's quite clear. Basketball, for example, it'll give you more around the metatarsals, higher incidence. The gymnastics, it go where to spine and pelvis. So yeah, and then that's how it's being distributed. In terms of when it happened, the basketball, they tend to happen in the preseason period. Athletes like gymnasts or the cross country, also the runners, they tend to have it a little bit around season around. So gymnasts, because they tend to train around the year. So in terms of when we see these people more presenting with, or when the suspicion need to be higher, basketball, football, it's probably during the preseason ramp up. Sports like gymnasts, they are just year-round. They might present with stress fractures. Why we want to know about biologic risk factor? I think it's more of assessing risk. So if we see someone coming in, trying to analyze, well, how's their training, what's happened recently, what's changed, what type of sport, how the sport affects, which part is predisposing them to a stress fracture. This is in general how the biologic risk factor affects the natural building blocks in the body, how they affect the hormones, and this will take us also to the other biology is the REDS, or the relative energy deficiency, and how this affects both the hormonal balance in the body, and subsequently it will affect how the bone resorb and build itself in time. I just thought I would just go quickly through the how the energy availability affects the like the susceptibility to a stress fracture. One of the interesting fact is, like, sometimes it doesn't need to be someone who's presenting with eating disorder for a long time. Sometimes a short period of energy, like availability or energy deficiency, actually might change the luteinizing hormone pulsatility, and this subsequently also predispose people to have a stress fracture. And in male is actually the bioavailable estradiol rather than the androgens that is closely correlated with the bone mineral density. So if later on it's in terms of investigation or trying to assess the susceptibility of male athletes. For the energy availability is the bone mass usually happens in girls around 11 to 13. Boys are a little bit 2 years later. And this is the maximum bone mass, the maximum build. So there's someone, for example, an athlete who are 20 who've been having energy, let's say, deficiency when they were 11 or 12. You would expect they, like, even if they are okay now, it's most probably they didn't reach the maximum bone mass. So it is still a risk factor. Even if they are functioning well, they don't really have any eating disorder or anything like this, they are probably also still at disadvantage because the catch-up will take quite a few years until the bone catch-up after the eating disorder is done. And then these are the other hormonal deficiencies that might occur. Micronutrients also is a factor. Low body mass index and bone mineral density. All of these are predisposing to that. The bones that usually are susceptible to the hormonal changes are the trabecular bones. So these are the ones that the curves that will show stress. It's, for example, things like the calcaneum, pelvis, the spine. This is the most susceptible to the higher metabolic change. There is also something about how the bone build itself. The bone resorption tend to be a little bit faster than the bone building. So sometimes if we go through some exercise and there's a lot of stress going through the bones, we're probably going to have a lot of osteoclastic activity to clear up the damaged tissue. But for a new bone to be formed, it takes months. So that's also one of these. That's why if you end up having a lot of training for a long period of time, tax the body.
And sorry, with that other one too, is that where, for example, would you see then, let's say, female gymnasts between the ages of 11 and 14 kind of like in that high risk population because they are peak bone acquisition?
Yeah, there's interesting thing about the gymnasts. The gymnasts actually they tend to have better bone in the lower limbs if they are basically out there practicing here, because that goes back to the loading, because they do have a lot of loads with the jumping. So in general, for the gymnasts specifically, they actually have a better bone formation in the lower limb, but they are more predisposed to fracture in the spine. Yeah, because the forces from going through the activity, they will accumulate better bone mass in the lower limb. And they might be osteoporotic, but if you do a DEXA scan, for example, for their femoral neck, it might come as normal because it's not resorbed enough because they accumulated a good bone in the hips and in the lower limb. And this actually goes way down to the third, fourth decade. So even if they stop doing gymnastics, they have a better bone mass in the lower limbs. Yeah. So yeah, I mean the risk about this, I would say if someone let's say an athlete who are in the college and they are 21 years old and they are having, for example, there is nothing extra in the training, but they've been having, I would say, eating disorder while they were at 11, 14, they probably started at disadvantage. So they already don't have enough bone there. So it's more one of these things that we will ask in history, for example. Yeah, was there any eating disorder before? How much this affects? For how long did you end up being hospitalized, for example? All of these things. Yeah.
But you do potentially see in some of those different sports age-related trends?
In terms of predisposing to a stress fracture? Yeah, I mean it's basically definitely the age of the athletes will predispose to injury in general. I mean at this age, 11, 14, the bones are actually still not really fused, so they still have their basically the epiphysis, the cartilage. So this is a whole different type of injury. So in terms of predisposing to injury, yeah. But the age, that I would say in terms of age, and the other one is the age is how much you build bone when you are at your growth spurts. Yeah. Right. Questions so far? So these are the biologic, which is basically the hormonal things related to that in nutrition. Then there are anatomic risk factor, which is related to how the body is being built. And these are some of the correlations that we found in some research, which is one of them is the narrow intermalleolar distance, which is from the medial malleolus to the lateral malleolus in the AP view. Some people measured it and they found anything above 73 millimeter, they have less risk in the lower limb stress fractures or the leg stress fracture. Other one, which was also interesting, is the measuring the widest circumference of the calf. And if the calf muscles are thin, this also predisposes people to the leg stress fractures. In terms of deformities, it's only the foot virus that's been found being associated with metatarsal stress fracture. And that's also one of the other research, which is it's definitely the shorter leg in leg discrepancy tend to be predisposed to stress fracture. And it was interesting. We just had a patient, I think, for a few days ago with the query. It was pain, but it was the history of SCFE in childhood, and you were blessed. I'm not quite sure it is stress fracture, but it was one of these. Tibial pain, it's focal, and it's the shorter leg.
It's one of the big ones slides. It's like interesting post-op stuff, right? So if you get somebody in, you're going to clinical suspect. That's fracture, and it's neat to see this. Right? Not going to be like watching people be like, oh, they got narrow ankles, you better do a different training program.
No, these are more, it's more, if someone having pain, well, you probably higher risk. And then it's flicking, I had this eating disorder when I was 11, and now I have a narrow calf. So all of these, build up, make you higher risk, Right, and then, so these are anatomic, some of the studies. Now it's the biomechanical or how the sport affect the risk of stress fracture. So that was, I just basically running, and there's the gymnastics as an examples. So these are some of the some of the suggestions that what can predispose us to stress fracture. And generally, I would say it's as long as there's more hip abduction, this seems to exert a little bit more force through the lower limbs. Things like overpronation also predispose to stress fracture. Everything here actually fall into that. So if it is a little bit more abduction, the stride width gonna be shorter, and this is basically you're kind of running this way. And then it's also the stride length. I might go fast to go to the real thing. In terms of other things related to biomechanics, running shoes doesn't affect it, except it's been found actually the minimalistic shoes that affect the risk of the metatarsal fractures. Other than this, there isn't really any other evidence for the orthotics or for the shoes. Okay. So for the gymnast, this is another form. I would say if I want to talk about something which they found interesting, because they tried to modify what's the risk for the gymnast. So they tried to change the stiffer landing from stiff landing to softer landing. And this is also made them more predisposed to stress fracture. And the theory is the force that been applied through the muscle to break the fall on unsteady surface tend to be also higher. So the body generated stress through the bone make them also predisposed to stress fracture. So there's no win in it. And this is something we mentioned. They are more predisposed to lumbar spine because their lower limbs are actually stronger, and they can carry on until the portic at a. Now we're going to talk about stress fracture. So there are two symptoms for stress fracture, and it's usually pain. And the one with the back, they usually present with stiffness or tightness in general. And that's also, I think, I find this interesting to know, because you probably might have more bone damage deep in the bone itself, and you don't feel pain. And this is what will make a difference between people have less pain and they will end up having longer healing time, because basically there isn't really enough nerve fibers deeper in the bone. So if there is a big damage there, they are not necessarily presenting with an agony. But if the damage was closer, for example, to the periosteum, where there's a lot of nerve fiber, but like the amount of pain doesn't correlate much with the amount of damage in the bone itself. And the initial stages of the stress fracture is it's basically like these are some of the characteristics that we want to differentiate from things like soft tissue, for example, like periosteitis or medial tibial stress syndrome, or all of these things. The stress fracture pain doesn't tend to resolve if you warm up. So this is one of the characteristics. We say, well, if you're pain, for example, you warm up, the pain goes away. It's most likely a soft tissue because the muscles and tendons tend to adapt and they feel better. For people who are having most likely stress fracture, the warming up doesn't really affect it much. And although we usually rely on things like hopping or trying to reduce the pain, the very early stages of a stress fracture, it's not gonna fit with that classification. So this is where it comes to, well, yeah, it's high risk of suspicion. Yeah, someone who is having narrow ankles or having this type of pain is highly suspicious. And then it comes when when it's a little bit more advanced, it's going to be one of the characteristics that if we talk about the tibia, for example, it's the localized bony tenderness. So some people comes with a little bit more diffuse pain. And it's unlikely to be a stress fracture, but if it feels more focal, and that goes with the patient we saw, and it was interesting because you move your thumb and then you say, well, it hurts here more, for example, and here it was like 7 out of 10, and then the moment I put the finger just below it, and it's like 2 out of 10, which is like quite like focal pain in one area, and it's characteristic, for example, junction of the middle third and the lower third, which is where people get the posterior medial stress fracture. So this will lift the probability higher. I would say these probably a little bit more advanced. I think by the time it's warmer red, it might be broken, but that's some of other clinical features. In terms of clinical exam, so these are our history points. Clinical exam, there isn't really much of validated tests in terms of reliability or specificity and sensitivity. But these are some of the clinical exam points. One of them is the endpoint, which is trying to for the navicular bone. And this is between the sensor houses and the tibialis anterior tendon, and this is one of the spots that's quite tender. The idea is we have to compare it with the other side. The drawback of it, sometimes the navicular stress fractures, they are actually happening bilateral. So if there is no difference in tenderness, it doesn't rule it out. Other clinical signs, this is for the femoral shaft stress fracture called fulcrum test. This is for the spine or the pars stress fracture, and this is with the one-legged hyperextension test. And then for the calcaneum, we have the squeeze test. All of these, they are not really well validated in terms of how specific sensitive they are. The one-legged hyperextension, I think it's got specificity around sensitivity, I think around 50–60%. Specificity a little bit bigger, but the other ones I couldn't find much of information about. Other clinical feature that has been researched, some people using this tuning fork test, which is basically put the 120/28 or 512 and put it distal, and if people feel the vibration cause pain, and it's not very specific sensitive. There is one feature that's been found that sometimes you send people for ultrasound and they actually feel more pain when the ultrasound is moving around the stress fracture. So that's one also of the signs that's been put in. And then
they missed out on that. I think it's called future.
Okay. Yeah.
Obviously, pain and sleep and stuff. Awesome.
Right. Yeah, no, that's true. Yeah, it's the pain that lingers basically. And it tends to be also the pain part of it. It's also almost fixed distance. Let's say I'm running and then the pain gets worse and worse compared to the soft tissue. The only one that interrelates with that with fixed distance is the chronic exertional compartment, which is on this graph. But yeah, that's true. Yeah. So after history, clinical exam, we usually go to our investigations. That's just a general historic thing. It's just to indicate that actual stress fracture has been diagnosed before the invention of X-ray. So that's what the slide is about. And then the X-ray being found, and then bone scan, and then the MRI became the gold standard from the 80s. The reason the X-ray is not really quite sensitive because we require about 50% of the change in the bone density for something to show up on X-ray. Other than this, that's what they call the gray cortex. There is something interesting about the cancellous bone. It actually says sometimes you see early an area of increase of ossification, because the bone tend to change from trabecular formation to a rod formation to deal with the stress, and if there is higher metabolic changeover, the bone structure change. So initially it might look a little bit more opaque, and then the bone structure starts to change. So these are the sclerotic bands. The second modality we usually use is the bone scan. The only drawback I would say about bone scan compared to the other ones is just the background radiation. Here is being quoted as this is a full body bone scan that basically equal to about 2 years of background radiation. X-ray, chest X-ray, usually about 3 days of background radiation. So this is just as a comparison. I think the CT scan is a little bit way more. For example, CT abdomen is about 5 years. Yeah. It is actually, it is specific. I think the low specificity, that's more of a general talk. It depends on where we are doing the bone scan. So sometimes femur, for example, is not really specific for stress fractures. In terms of if we want to do a bone scan for things like femoral neck, or also the other one, which is not very specific, is the sesamoid bone in the foot, because there are other things that make things light up, and it's not really beneficial. Ultrasound is emerging as a modality to diagnose stress fracture, and these are some of the findings on the ultrasound. The sensitivity vary because it also depends on which body part we are basically scanning. And then CT scan is not that important because we do have other modalities that compensate for it, and it's also the amount of radiation that it exposed the patient. It still has value mostly actually in navicular stress fractures. Even if the bones can light up, I think the CT scan is needed for staging, which is whether it's stage 1, stage 2, stage 3. So it has some role in that. And then comes the MRI, which is the gold standard. So the general sensitivity specificity in terms of stress fractures is between 88 to 100. If we think of the lower extremities, is way higher, which is most of the time where stress fractures usually happen. We don't have radiation risk with the MRI, and the other benefit about the MRI give us some indication about the period of lack of sport. So it's prognostic. It's none of the other ones that can give us that information. These are the stages, but there are 3 classifications by 3 different, I think, radiologists or different studies. Most of the ones that we quoted is the Fredrickson one. These are stage 1, 2, and 3, 4. And this is how it correlates in general. So grade 1 on MRI, you would expect rest for 3 weeks. Grade 2 is probably between 3, and then if it is a grade 4, at that time you're expecting something more than 16 weeks of play. Right. So these are the general thing about stress fractures. These are the higher risk bone stress injuries or stress fractures. I have all these in the coming slides, but for the sake of time, which one we should talk about? We can do the anterior cortical tibia. Yeah, that's the dreaded black line.
Because when you see lots of units,
That's right. This one is actually interesting. It's very, very rare. Yeah. So stress fractures in the patella. It's extremely rare. But the interesting part, this one actually sometimes happens after ACL with the patellar tendon graft, especially the ones where flexion contraction, and it said the theory is the stress riser in the, but they are quite rare. Yeah.
someone else would like tibia too on the chat. There's another vote for tibia.
Right. I put the online one. They don't have the right to vote.
Well, someone can get one thumbs up too. At least 2 votes for tibia.
Yeah, that's true. Yeah, the tension side. Yeah, so that's basically, it's also different between compression side and tension side of the femur. Okay, let's start with the femur, and then we have the tibia, and I can jump into prevention treatment, and there's time I can go back. Okay, so that's the femur. That's basically the incidence from these stress fractures in general, and this is in the collegiate athletes. In general, this is mostly diaphyseal. They do happen. There's also distal metaphyseal fractures that happen around the medial condyle or the lateral condyle in general. It says like this has previously been known as osteonecrosis, but it's now being considered more of a stress fractures. Most of them, they involve the medial proximal cortex, so it's the inner part of the thigh, which is the compression part. So there is like the reason, like even around the leg is the compression part because it's the muscle part. So it puts more load around the bone. But the interesting part, the compression part heals better. So that's the. the benefit of it. So this what comes where the clinical feature for the femoral shaft, which is tend to be really vague, poorly localized pain, often diagnosed as a runner strain. That's the Fulcrum test we did initially, which is sitting someone. Sometimes you can put your hand under the thigh and pressing down. That's one of the features. The other one, make them hop, which tend to be a little bit more advanced stage of having a stress fracture. So reproduced by hopping. I would say it's still the MRI is the go-to investigation. In terms of the treatment for the compression side, like for anything that it is not on a tension side, is going to be conservative. And the weight bearing status, I would say, depends on pain. If someone's really painful, they can end up on crutches for a week until they are better, and then they can progress to load bearing, and subsequently they can go forward. Some of the measures that you can use is like these training in pool, let's say, and this is reduce the weight. So you can keep training or cross train. That's for the athlete. See, there should be a femoral anatomy. So that's the patella, tibia, and I'm quite sure we do have the femoral neck. I do have the femoral neck, I'm sure. So these are the general patella we talked quickly about, and then that's the tibia. So this is the tibia is that's the compression side, which is the posterior medial, which is the most common. The one which is high risk is the anterior tibial fracture, which is up in the middle of the tibia. It's in the front. I can talk about both while going through the slides, so that's also help us with time. The one which is the most common usually happen in runners, people who run. So it's the posterior medial or the cross-country, the skiers, cross-country skiing. So this happens in the compressive side of the bone. It's usually the lower third of the tibia. And these are some of the biomechanics that predispose to this type of stress fracture. The ones that happen anterior, they happen in different type of athletes. The ones that involve jumping, the sprinters, they tend to have a little bit the anterior tibial stress fractures. So this is one of the most common fractures that happen, and this is the compression side, and this is the posterior medial tibia. And this is just how you differentiate it from the other causes of leg pain, for example. So most of the time these are basically combined. So someone comes with the posterior medial leg pain, happen with exertion, it's vague, they don't know yet, sometimes carrying on during the exercise, sometimes stopped. So these are some of the features that sometimes help us kind of delineate what it was. The stress fracture tend to be more focal. They tend to be basically continue after the activity. There's the exertional compartment syndrome that also kind of overlap with stress fractures. This tend to be commonly bilateral. It also tend to be most of the time with a fixed distance, and sometimes it's associated with some neurologic findings. So numbness in the foot or the plantar area. Popliteal artery entrapment is also another differential diagnosis, but this is mostly cough, discomfort, cramping, and they get better immediately when they stop. Sometimes numbness of the foot.
How common is it for Panama people to have tibial fractures?
Like the local epidemiology,
How many people come to this clinic and have fractures? Other than trainer, I don't know.
Yeah, other than the one, I think in the past 6 weeks, it's probably one suspected stress fracture. But that's basically changed. It depends on the people you see. Most of the time, these, as we chatted, most of the time these are in athletes who are basically having increased load of training. So you'd expect these early in the training period. So beginning of the season, it's higher susceptibility, you see them. But as a fixed number,
you know,
So, and in the line over here, they probably see most of them being the cross-country biathlon.
yeah,
I don't tend to see a lot of
Right.
education population for that. Yeah, it's not super common, collegiate career.
right.
So,
Yeah, so it
Depends
depends
on the crisis.
no, you just gotta keep that political discussion, really, if somebody's training to too hard, it's that,
Yeah,
yeah.
Yeah, and that's the idea of putting the high risk, because by high risk, mean these are the ones that predisposed to basically non-union or they progress to a complete fracture.
right.
So these are the list of the ones that it is like you wanna keep thinking about, because missing them is it's a little bit too big for the effort. Yeah. Yeah, there was one 16-year-old who kind of have an overlap actually between these two. And the interesting part, as an added thing to the exertional compartment syndrome, this is it's a young athlete who after she runs for a period, she received the feedback that she's slapping on the ground too loud, because that's the muscles get weak and the nerves get weak. So you don't have enough to lift your foot. So you're running, the running sound change. So that's also another feature we can add. And that's the popliteal artery, which is also one of the things we can keep in differential. Yeah. So that's in terms of like another form of the assessment. Initially, that's why it's a little bit confusing. So grade 1 injuries, they tend to be a little bit more diffuse pain. So trying to differentiate this from a medial tibial stress, is it basically a deep compartment? Because most of the pain happens in the posterior medial tibia. So deep compartment syndrome in the lower leg, this is where you have pain. Medial tibial stress, this is where you have pain. Early stages stress fracture, this is basically where you have pain. So this is where it comes, features from the history, predisposing factors that will sway more of the clinical suspicion of one arm rather than the other.
Let me jump forward to the treatment side.
Sure, I'll be done. Okay, so fibula, that's the femoral neck. Just one thing is there's difference between tension side femoral neck and there's difference between compression side. This would be considered more of a surgical referral directly, because the tension side is the one that's basically on the outer side and it's always going to be pulled up and it's easier to progress to a complete fracture. So that's surgical. This can be treated conservatively. Navicular is here. Calcaneum is here. This is the fifth metatarsal, sesamoid bones. And that's in general, like each one of them is usually the treatment, but like most of the treatment depends on of the sport for a bit until the pain settles. Non-weight bearing most of the time with the anterior tibial stress fractures, navicular fractures. These are the ones that they need to be off weight bearing if it is too painful. Right. Does this enough for the treatment? Yeah. So the general line of treatment, yeah. If it is anterior tibial stress fractures, navicular fracture, lateral process of the talus, all of these, they're going to need to be non-weight bearing. Navicular works better. I need surgical, I would say, consultation. Need a CT scan, and surgeon need to know about it. Medial malleus stress fractures is worth talking to a surgeon also, because they perform better with early fixation. The fifth metatarsal joint fracture also refer to a surgeon. They perform with a shorter period of sport. So these are basically, if we want to differentiate it. And the other one, the most famous one, is the anterior tibial stress fracture, which is the mid anterior tibia. These they should be off weight bearing for a bit, at least until they are comfortable putting weight on the leg. And one of the things we can use for them is the pneumatic, like this, the air boots, which help with the treatment. Yeah. So these are, I would say, the general guidelines for the treatment of stress fractures.
So in the line with prevention, you say 2 to 6 weeks, your fracture can start to
Yeah,
to get billed, so if someone's like a power lifter, they should change their program, which is aligned with my training anyway.
mhm.
Every 6 weeks, they should change to a different intensity, to different cross training.
You mean if they have a stress fracture or?
Well, to prevent it.
Yeah, yeah. So that's one of the things that, yeah, like strengthening other parts. Let's say, for example, runners. Most of the time, if you want to build endurance, you just running.
Yeah.
But if you really want to have a preventive measure, you need to work on strength.
Yeah.
Because that's where you have,
Sizing,
yeah,
strength
yeah.
sizing,
So you have to
change
focus,
that.
yeah, you have to focus on building some muscle.
Yeah.
Because this is where it's gonna help with the sharing blood that goes on the, yeah. Yeah, and the other one, if they have stress fracture, is the cross training part that goes on.
It's so cool how 6 weeks is like that point where it's changing a program maximizes stimulation, but it also helps with joints.
Yeah.
To change up the program, and now I can shed a light on.
Yeah, I'm not quite sure about the exact time period. I mean, in general, this is the recommendation initially. Yeah, every 3 weeks, you should have a week where you are less load, so your bones can have enough time to heal. But I would guess it depends on how much the training before that.
Yeah.
So if someone having
too much weeks is a magic window for a lot of things.
Yeah, yeah. And the treatment wise for stress fracture is not everything 6 weeks. It depends on the stage of it. So
Right.
some of them might take long. Yeah. In terms of trying to prevent stress fracture, there's one thing I was interesting, and it says here, it's actually people who consume animal protein rather than vegetarian protein are less predisposed to femoral neck stress fractures. So it seems like the type from where you're getting the protein does make a difference of how the bone builds itself. So that was sorry. Yeah, but it's still it's still the protein you're getting. Yeah, not quite sure. Yeah. I just thought yeah, that was one of the interesting facts being mentioned. That's yearly single sport specialization, which you basically similar to probably the things you talk about. So this is where they advise, for example, kids at school, they don't focus on one sport because you're basically gonna build one in one area and then you forget the other ones. Sleep is good for regeneration. As I mentioned, these are a little bit more conflicting, and then trying to modify the training. Other elements other than, let's say, the weight bearing status, there are, for example, for people who are having energy deficiency or hormonal imbalance. The interesting thing being mentioned is actually the OCP itself, the oral contraceptive pills, doesn't help with the bone building. Taking the patch actually does affect the bone building. But the problem with the patch, and especially if we talk about athletes, you still have something on the skin, and you also have to get progesterone in the last 2 weeks of the cycle. So it's trying to coordinate a little bit different. But the reason for it is the estrogen in the pill get metabolized in the liver, and the metabolic part of it doesn't stimulate the insulin growth factor, because the way it seems the estrogen works is stimulating of the insulin-like growth factor 1. And that will basically start building the bone. So the patch is actually the one that will produce that effect, not the pill. Other things, there is hormone called leptin. That's also a bone stimulant that can be used. And the insulin-like growth factor 1 is anabolic hormone. There is one thing, and this is one of the discussion points. I actually spoke to the pediatric eating disorder clinic, because most of the time these people, they come in, they don't treat them basically with hormonal therapy. It's more focused on psychology of eating and they didn't recommend starting hormonal therapy earlier, especially if you have a very young patient. But this is one of the things that we found. These are basically not an eating disorder patients, but I would say more predisposed to energy deficiency or basically eating disorder. Start giving them hormone replacement therapies actually help with the improve their eating behavior, reduce their anxiety, improve their cognition. So it was one of these things like, well, do we do these patients, for example, enter a vicious circle? They train too much, they are too hungry, they are too anxious, and then they are less likely to eat, and then they will go on to this loop. So the question is, well, should we start these when we see someone who's a little bit more predisposed? So we break this cycle of making them slide into an eating disorder. Pediatrician said no. Other modalities that we can use for treatment, the only thing that has been gaining strength is the shockwave that's been used to improve the healing time of stress fractures. Other modalities are not really as much evidence, whether it's the ultrasound or the electromagnetic stimulation or this low pulse ultrasound. PRP has some animal studies that shows improved healing with the stress fractures. There's also PRP studies done in orthopedics that basically treatment of fractures, and they found it helpful, but I'm not quite sure about stress fractures in general. There's one thing interesting which is being mentioned. There is some research about intraosseous and interarticular PRP for people with osteoarthritis. And they are saying this might have a role. It's treating early stages of stress fracture, which is when they have inborn edema, which is doing intraosseous PRP. Right. That's one interesting image that's been found. That's someone born without tibia. They transferred his fibula as his tibia, and then by the time he grew up, it became tibia. This is just how the bone responds to external load, depending on where it is. Everyone's awake.
It's interesting, just that one slide, well identified before X-rays, even and then we've got all these other things to go into these great depth analysis and crazy medication, and insulin growth factors, like sometimes a little bit of wisdom. Are you training a lot? You're so good. Yeah. And don't specialize. So yeah, I've got all this 200 years of history that we have seen in that place.
Yeah.
All right, question: who is Volkman? What was Volkman born for? Name something else Volkman's named after himself.
Volkman?
Way back at the beginning of your slides, you talked about Volkman canals and convergent canals.
Oh, I don't think it has anything to do with stress fractures, so I'll pass.
Yeah.
I think Volkman is a scientist who has interest in curiosity, and he discovered something in bone.
Volkman contracture?
Volkman contracture, yeah. So I mean, if you want interesting fact, John's fractures.
Yeah.
So John's is a physician. The first case series, the six patients he published, he was one of them with the fifth metatarsal fracture, and he broke his foot while he was dancing. But the interesting fact about John's, he's actually the nephew of Thomas Splint.
Oh.
Yeah, that's his uncle. And it says his uncle was weird enough that he was rejected from working in every hospital in England. He ended up having his own private practice, and he invented the Thomas splints for the femoral fracture. So, I mean something interesting. yeah. So that's John's fractures. Let's see. And the other thing about I think John's fracture, I think his initial description of the fracture is actually the diaphyseal one. The one that has been reclassified as John fracture is done by someone else, and they classify this as tuberosity John fracture, which falls at the metaphyseal diaphyseal junction, and then this is a completely diaphyseal. So this actually now the grade 3 or type 3 was initially John's in his population. But it's been revised. They kept his name, but they moved it a little bit. Those are there, yeah. So yeah, this is one of these things that probably surgery works better for people. So that's zone 2 is John fracture. And these are the zones 1, 2, and 3. And yeah, that was one of the ones that's also very rare. But that's what sometimes, like if it is a complete fracture, this is the snowboarder fracture, which is the lateral process of the tendons. That's one of the things that is also important not to miss. Yeah. I finished on time. I never finish on time.
And then,
Yeah, any questions? Happy to hear any questions.
So popular age for stress fractures?
Popular age?
Yeah. I know you got it.
Oh, thank you. Thank you for coming.
I guess it depends on the sport and what they're doing. But
Yeah.
people in the mountains out here, they're popular age. You see a lot of these people, we might see a lot of these.
Yeah, I would say it's probably the younger athletes that they would be predisposed to stress fracture. I think if you go older, a little bit, yeah, it depends on when you draw the line. I'm not gonna give numbers. I mean, most of the time later on, you probably have what we call them insufficiency fractures. You probably have your joints gonna take the beating, so you come up with arthritis rather than stress fracture because your joints gonna wear down before your bone breaks. Yeah, so this will stop. It will be a protective factor. Yeah, and that's why people who have been osteoarthritis of the head, they don't break their hip if they have it severe because the bone tend to be really like it's overcalcified.
When they're older, yeah.
Yeah.
No, little fractures.
So I would say, yeah. So if you have a stress fracture, consider yourself young.
That's nice. Okay.
Yeah,
Any other questions?
so that's the navicular. Yeah, I think the general thing treatment is going to be basically patient specific. So navicular tend to be probably going to need non-weight bearing. These are one of the things that we want to keep in mind. So these are, let's say, the list we listed out here. Let's see. Most of these, they might require a period of non-weight bearing. So the tension side of the femoral neck is done for surgery. Anterior cortex of the tibia, they're going to be non-weight bearing for basically 6 to 12 weeks. And then the reintroduction, if they didn't heal within 3 months or 6 months, they're going to need to be referred to surgery to get either nailing or plating. Medial malleolus, they will require surgical referral. Patella in general, they are very rare that they are not being studied treatment-wise. And this will depend on patient by patient. Most of them, they're going to need a little bit of splintage, non-weight bearing for a bit. They might need surgical fixation, depending if it is transverse or longitudinal. Most of the stress fractures, like the stress fractures without surgery, they tend to be lateral longitudinal, but the ones after surgery, like after ACL, they might be transverse. This one, gonna need a CT scan to evaluate what's the depth of the bone stress fracture, and they might need referral to surgery earlier. They need non-weight bearing. The fifth metatarsal, the Jones fracture, they need non-weight bearing, and they also benefit from yearly surgery. Sesamoid, they need non-weight bearing for at least 6 weeks. That's annoying small bone in the foot. So yeah, that's one of these things that might require a period of non-weight bearing. The problem with these, sometimes if you excite them, especially in athletes, you lose a little bit of your push-up, about 10% of the push force in the foot, so you don't want to do that. Yeah, so you have to treat them out.